I'm Danielle Hicks. I'm Chief Patient Officer here at Go-To for Lung Cancer. Tonight's conversation is around improving healthcare delivery. We talk a lot here about clinical care, what good should look like from, pre-diagnosis through diagnosis, treatment, and survivorship. What we don't talk a lot about is what happens behind the scenes. What should you be expecting at your healthcare center? What sort of processes and quality improvements can be put into place to make that part of the experience even better, and how it actually relates to better outcomes for people who are being seen at centers who have these quality improvements in place. Tonight we have Dr. Mohana Roy, who is the Clinical Assistant Professor, Associate Medical Director of Cancer Quality at Stanford Department of Medicine. And I did want to read something, and I pulled this, I can't remember which source I pulled this from, but it really resonated with me around tonight's conversation. So quality is defined, here it came from the National Academy of Medicine. Quality is defined by the National Academy of Medicine as a degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And quality improvement is that framework used to systemically improve that care. Quality improvement really seeks to standardize the processes and structure to reduce variations in processes, achieve predictable results, and ultimately, and most importantly, to improve outcomes for patients diagnosed. So before we sort of jump into what good does look like from your perspective, what we're really talking about is from the moment someone walks through that door, whether the diagnosis has been made or whether they're there for their original biopsy to see what is going on, there are certain processes that can be put in place sort of behind the scenes to ease sort of the transition or the navigation through what might be to come. But I think it's also, and we talk about this a lot here, and this is a part of it that we don't really talk about, when we think about treating the whole person, we don't really think about the processes or what is that sort of behind the scene thing. And it's so incredibly important and can really drastically change what someone's, I hate using the word journey, but what someone's journey through the process would look like at some place that maybe didn't have some of these put into place. So there's 13 sort of points, I guess, of things that people should keep in mind, or healthcare providers and institutions actually should keep in mind. So it's showing respect, expressing gratitude, enabling access to care. We talk a lot about access to care in here. Involving patients, family members, and friends in the process. I mean, we see a lot of people in this room, and I know online tonight, that are walking alongside their person throughout all of this. So involving them is a huge part of this. Coordinating patient care with providers. We talk a lot in here too about multidisciplinary care and who's navigating the process from your medical oncologist to your radiation oncologist, or from your pulmonologist to your surgeon. Who's managing that, and what does that look like? Emotional support. There's a lot of centers who aren't Stanford and are smaller, treating whatever type of cancer walks in the door, and may not have resources on site in a lot of these cases, but to have external resources to be able to refer these people to is incredibly important, and that's where groups like Go-To and others can come in to help with some of that. Engaging patients in their care plan. That's that whole shared decision making that we also talk about a lot in here. Having a conversation at a level with your healthcare provider that you can understand so you can make informed decisions. And it's even more important, I think, today, given the complexities of lung cancer and sort of between targeted therapies and the subtypes and immunotherapies and combination therapies. There's so many options available. Being able to truly understand what your options are so you can make these informed decisions, addressing whatever physical needs your patients might have, supporting mental health. And mental health, I think, is a big miss in a lot of this. Somebody being faced with a cancer diagnosis at all, let alone a lung cancer diagnosis, is gonna have some struggles, right? And being able to support them and acknowledge them through that is incredibly important. Quality patient experiences, which I think is sort of goes without saying, and then streamlining care management and what sort of external resources can we use, i.e. technology. So does that kind of cover what we're talking about here today, and do you have anything to add to it?
No, and exactly, and I always think that the 30-minute visit is such a disservice. And and hence we run late, and all of you are very familiar with that. I have been really interested in how do we decouple from that 30-minute visit. So what can we do outside, in parallel, maybe more frequently, so that it doesn't feel like everything needs to be done in those realistically 20 minutes by the time you've gotten your vitals done and then you're waiting, right? And so mental health, for example, really thinking about screening before the visit and to kind of upfront say, you know, these are the things we'll talk about today. We're going to talk about your cycle 2, day 15, but like these are all these other things we need to address. I probably can't do that because honestly it would take an hour and I wish I had an hour, but how do I effectively make sure that doesn't get missed? And that's a lot of, we'll do a little bit of the examples, but the couple things that really rung true is I do think that access is a big issue. That's one thing I wanted to talk about today. And then I think, again, consistency. So many people have amazing caregivers and family members who unfortunately have to remind us it's a very reactive medical system. It's like, oh, Dr. Roy, you forgot. You know, you promised me this and you forgot. And I'm like, oh my gosh, you're right. I forgot. I didn't have a way to keep track of that. And so those types of things, like why should it be based on a person reminding to say, oh, did you mean to have a follow-up appointment and you didn't do that? So those are the type of things that can we automate some of that so that it's not such a individual, I would say, error-prone process.
And I think that's fair. I mean, I think we can all do better, right? Whether it's in our daily lives or professional ones or otherwise. And I think one of the things I love about you and your particular area of interest here is that you're focused on identifying when you know something can be better and then trying to be solutions based and how can we see to it that the next person that walks through this door doesn't have to do
right.
that. I want to get into the priority setting for quality improvement. Can you talk to us a little bit about that?
Yeah, let me tell you, just kind of set the scenes again. This is behind the scenes. I don't think we talk about this much. Most large centers have like a quality program. So Stanford has a quality program, and each year we basically set our priorities of how are we going to measure this very ambiguous word, right? Quality. So there's, you know, two major categories, I would say. One is like, what did we mess up? What did we mess up last year that we need to do better? Again, things you may not directly know about. We have actually a safety reporting system. So anybody in the entire organization can put in like, this was a mistake, and that gets reviewed. We actually review every death that occurs for our patients and review what could have been done better. And there's a clinician, so usually a doctor, and then a kind of quality analyst who looks through those cases. And so we have built in really, I think in my line of work, I feel like there's not a lot of times for pause. You know, I'm kind of just going to the next thing. And so one piece of it is reactionary. It is, you know, what was missed, what was not done correctly, and accountability to say it's almost never an individual's fault, like ever. I think it's like, okay, clearly there was some miss in reminding or scheduling, and that didn't happen. So that's one piece. The second piece we do a lot of is that we do have professional organizations that hold us accountable. Insurance companies hold us accountable, and then there's large kind of quality organizations. There's a lot of, I would say, controversy on that, on how much of that is truly meaningful or not. But those are, what my job is to pick through all the requirements and say, what does actually sound meaningful? So I'll give a few examples if that's okay. And so there's something called QOPI. ASCO, our large kind of oncology organization, has a quality certification program. I led that effort just last year for all of Stanford. It's like, I think, 150 things we're supposed to do. And some of them are kind of hard to prove, but they make you think, like pain documented consistently. Do we have a follow-up plan for oral chemotherapy? Is it documented that I'm going to talk to you every 3 months and then every 6 months and then check blood work this often? And what is the expectation so that a stranger could walk in and say, oh, this is clearly the plan. Have I clearly communicated prognosis, at least initially, and given an expectation of what things are like? The thing that we still don't have figured out is that I would like to think most of us do a lot of this, but the bane of our existence is documentation, if you don't know that already, for doctors. And so a lot of times we just don't type it up. We don't write it. So my job is to kind of glean, trying to peel this information to kind of show that good care was delivered, but the proof is in the pudding, and sometimes it's hard to prove that.
Is any of that tracked in EMR?
It's almost all EMR. So one very good example is stage of cancer. You would think that I could tell you very easily what % of our patients have what stage cancer. That's a very simple question. It's in our notes, but it's actually not in what's called a discoverable field in the electronic medical system, because that requires your doctor to click 5 more buttons that we don't want to click. So we just write stage 3 on our note. As a big picture data person then, there is no way I can capture that information. So I think hopefully AI, it's supposed to be the new thing, right? So AI, large language models, those are things we're looking into. Can we comb through paperwork that exists that's not so computer focused and still glean that this is, yes, this patient did get good quality care. It's again just really hard to prove. And so I just wanted to give an example. This is not meant to be read in any ways. I just wanted to echo, I think, Danielle, what you were talking about, this kind of patient journey from start to finish and what that looked like. So I put in some things at Stanford we're focusing on. This might look very different from each medical center as far as what priorities we've put into place. So I think the first one, screening, is a huge issue, as I'm sure your programs have highlighted many times. The thoracic surgery team, for example, has really taken that on, and they did a unique project on pairing lung cancer CT scans with mammograms. So because mammograms are so much more, I would say, socially aware, people know about it, and so Dr. Leah Bacchus did a very interesting project on why don't we just remind people to get their CT scan when they're going in for the mammogram. So those types of innovative projects are what we're looking for. It is hard, I will say. We do a lot of one-off small projects, and then how do we decide to actually take that on as a whole cancer center is a whole other beast. Mm-hmm. But things like, what % of our patients who are eligible for screening get captured. I think we're very much in our infancy, to be honest, to really be able to capture mm-hmm. that. A couple things more directly that I'm working on and that our group's working on, we're trying to set up a diagnostic clinic. So historically and even currently, most academic centers, you need the checkbox. You need the PET scan done and the MRI done and the CT done and the biopsy has to be done, and you just have this whole range of requirements, and people, again, I would say less resourced usually, I think really have months before they see someone like me. And then they get to me and they say, oh, gee, I finally made it to the Stanford doctor. I'm really glad. And I say, oh, wait, well, now that PET scan's really old and we need to do the repeat biopsy and your molecular testing's not done. And oh, the biopsy's inadequate, and I see some nods going on here. And by the time I'm giving care, it feels late. So access from that point of view, I think, is a big quality issue. And then we get you into our world, and then we say, it should be easy to come back and see your physician, or at least a nurse practitioner, physician assistant. I think the behind the scenes thing is that doctors, we send a lot of messages to each other. And I always joke that there's like 10 ways to contact me. So I'm constantly I'm like, oh, did someone email me? Did they text me? Did they send something to the electronic medical record? Did they send like a dove flying? I don't know, maybe I missed something. And so there is actually a lot of good work done, again, behind the scenes, but it shouldn't take so many little, favors, essentially, to kind of streamline that. So we're working on everybody gets a guaranteed follow-up visit after an unplanned hospitalization. Kind of, again, this is not brilliant, cutting-edge cancer research. This is like, just
it feels like common sense.
Common sense.
Yeah.
That's what I was going to say. Like, this is not a brilliant idea, but we really haven't thought about things as processes so that it doesn't have to be a one-off of like, oh, well, this person got a follow-up, but then these 5 people didn't. So early access to care, initially a diagnosis, follow-up consistently when able. And then the last piece we've really tried to focus on is something that's very hard, but really documenting any type of serious end-of-life conversation we've had. We've had lots of cases of, I think something about a patient of mine, but once they get admitted to the hospital, that doctor has no idea about that 1 year or plus relationship I built to that person. And a lot of times, it's like, oh, gee, you have lung cancer, like maybe you shouldn't go to the ICU. Maybe that's true for many cases, but some cases, no, you should go to the ICU. You actually are fine. And there's a lot of stigma around cancer. There's a lot of stigma around lung cancer. And so I think it's our job, again, to not overburden the documentation piece, but really say that it should not take, again, special one-offs to have some of these kind of standard things in place.
And I think that's important when we're thinking about treating cancer today, especially, is very different than treating it 20 years ago, right? And the personalization is important from a clinical aspect, but to your point and sort of what you're saying, it's also important from a personal wants and wishes sort of aspect. So having that documented and understood is an incredibly important part. Going back to screening, I love the idea of the mammogram, CT. I know others, us included, are looking at it. If somebody's going in for a heart check to look for plaque or whatever kind of buildup it is, we should also at the same time be looking for any abnormalities in the lungs, and really connecting those two I think will help, because screening in this country is dismally low, especially considering how long it's been approved and available. And I know ACS recently made recommendations about removing that 15-year rule, so you must have not quit smoking longer than 15 years ago in order to qualify, which we all know is really silly and makes no sense.
Yeah.
And now we're just waiting for the USPSTF to jump on board, because we want to make sure that we can get it covered outside of the original thing. But anyway, and I always say to people, particularly those who are watching this programming, we've passed that port, right? Like, we're working with people who are already diagnosed, but who better than someone living with lung cancer to be having these conversations with people that they know qualify by today's standards. Mr. Larry.
I have one question about screening. I've always wondered, is there any way to, in an electronic medical record, flag that? Because if I think back over years, 50 times maybe, someone has asked me if I smoked.
Yeah.
So if it's in the electronic medical record, even the primary care doctor can see that and have a quick discussion about screening.
Yeah, no, that's such a good question. Even though, Larry, they've asked you that 50 times, I guarantee you they have not gone into the EPIC module for smoking history and entered in the number. And so I really hope, I know that electronic medical records were like the big aha, right, like 20 years ago. And I think they have improved a lot of things. I will give it credit. I really think there is a disconnect on, again, the button clicking and what happens to a person. And so those times we've asked you, we've just written it in a note. It's under social history, and it's 50, and it is not discoverable. And I think, I'm hoping, really hoping, that the aha moment is going to be all these amazing Silicon Valley, very smart people are going to help me translate that 50 time answer into a discoverable thing that then you can build an algorithm for, but it doesn't require the doctor who literally vouched to not be at the computer just entering little buttons. And so that's the disconnect. It does actually exist, in radiology, where they have protocols, of course, for existing lung nodules, and they have kind of tracking for that. But just from a smoking history, we've honestly really relied on primary care, who do a much better job at filling out those boxes more than oncologists, but it's just unreliable. If someone enters 5 instead of 50, that's a huge difference. There's things that are prone to such easy human error, and there's so much wealth of information in notes. It's just that it's not discoverable in a meaningful way, but I'm hoping we will solve it.
I agree, and I think that there's definite opportunity for improvement when it comes to the technology in this space, because when I think about my own healthcare, sort of experience, when I turned 40, it was you're getting a mammogram. When I turned 50, and they weren't just telling me at my doctor's appointment, I'm getting emails, I'm getting stuff into my patient portal. You know what I mean? So how can we get the screening for lung cancer bumped up to that? And even if we're not tracking smoking history, should everyone not just get it? Like, here's the criteria. If you meet it, let's have a conversation.
And it could be like a one-time, like we don't want everybody getting CTs all the time until there's a easier modality. But, we worry a lot about now family history, right, with some of these targetable mutations. And the Asian countries are ahead of us in, some of those guidelines.
Yeah, a lot of you have heard us talk about it, and we will be having a living room in the very near future about it, but about this inheritable sort of possibility around lung cancer. And I think a lot of you who have been with GoTo for a long time know that a few years back we ran a study called Inherit through Alchemy. The Addario Lung Cancer Medical Institute partnered with Dana-Farber. Jeff Oxnard was the PI on it, looking at T790M, which I think a lot of us know is what was always thought to be a resistance mutation in EGFR, found to be actually a germline mutation, right? So we're getting ready to launch phase 2 of that, looking at folks who have either been diagnosed or people like me who have multi-generations of family members who have been diagnosed, to go on and enter the study and see what we can find out, right?
Yeah.
It's really, really exciting. Again, it's with Dana-Farber, Alchemy, and GoTo. We're more to come on that. I just needed to kind of throw that out since it came up, because we are really excited about it. We, outside of folks who have already been diagnosed or who are actually at risk and fit the screening criteria, we get a ton of phone calls about people saying, well, I don't qualify, but, right? And then one other point to make, I don't want people to be afraid of low-dose CT screens. People worry about radiation, and I think a lot of times what we don't know, and again, people who are familiar with this program have heard me say it, I get up on my soapbox about it, but, for example, last week I flew back and forth to Fort Lauderdale, Florida, and I get the same amount of radiation flying back and forth on that airplane as I would in a low-dose CT scanner. So, and there's no signs at the airport, by the way, when I'm getting on the plane, letting me know that. So, although we can do better, and I think we should do better from screening across the board, it is a safe option, particularly for those at high risk.
This is actually just a snapshot. I was looking at lung cancer specific quality metrics specifically for this program, because my job is to look at kind of all of the cancer center and cancer center wide, pan-cancer. So I think the couple lung things that I would love to focus on, I know this program has talked a lot about mutation testing and biomarker testing and appropriate biomarker testing. I am concerned about timeliness of that. Again, just kind of getting down to the nitty gritty of it takes a long time to get those results. There can be, again, insufficient diagnoses. So we are, again, trying to open a clinic that will just see you sooner, essentially. That's my answer as far as, again, from a process piece, to do the testing sooner.
Can I ask a question about that, particularly around biomarker testing? Because we have tissue testing, and then we have liquid, right? So looking at right now blood anyway. And I know, although I don't think it's standard practice across the board. I know a lot of docs are doing both at the same time. Can you talk a little bit about that?
Yeah, so at least in our group, I think we do both pretty much all the time. We usually don't do blood if it's more early stage disease, just because we A, don't have approvals for that, but B, we really think that the blood circulating DNA has correlation with kind of amount of tumor and disease present. But I would say anybody we think is like a stage 3C plus, and definitely stage 4, we are doing blood. And again, tissue is gold for us. I always joke that I still have a texting thread with the colleagues I trained with, and it's called Tissue is the Issue. You can check my phone, it exists. And so we really rely on tissue, of course, but I think the blood test is really our way, again, to really address a quality process issue, which is we just want information sooner. And this is where I think data and the patient experience sometimes vary, because there is unfortunately data showing in some cases where perhaps a 2-week earlier treatment for metastatic disease does not improve survival. And that's harsh, but that's just what the graphs show. But I think all of you would agree that a 2-week wait, regardless, is excruciating. And that's the divergence, right? Of like, there's the people who are looking at the numbers and say, well, that person can wait. And it's like, well, can they really wait? Or, you know, their anxiety and fear and just all of that, I think we don't have a good measure for that. So that, sorry to divert a little bit from biomarker testing, but I think sooner is usually better. I would say most people, even when I'm giving them very bad news, are happy that they at least got some news. And that's how I kind of frame it.
And I think you're right on point, because I mean, timeliness is not just around biomarker testing and how quickly we can get back the results. It's around having follow-up CTs to see sort of what's going on, and then making people wait 2 weeks for the results of their follow-up. And scanxiety is a very real thing, and this kind of points back to mental health, and the circle goes around and around
exactly.
and around.
Yeah, so I think sooner is better is the one observation I've had, and that is it's not really data-led, it's more just people-led, and it kind of goes back into the access point of view, is that I usually tell people I much rather see a rash and say, that's nothing, you worried about nothing, but I'd rather know, and then it's a quick visit, and then it's fine.
Yeah.
But usually just that getting in is such a hard piece that I really think we can improve on that.
Yeah, and I know we're going to talk about this a little bit later in the program, but this is where patient-reported outcomes and registries and surveys that I know a lot of you have participated in are so incredibly important. Hearing from the horse's mouth exactly what's going on can help with some of these quality improvements.
Exactly. So this is just a little bit more information I've already talked about. There's data to kind of really say that earlier is better as far as actually some patient outcomes. Certain cancers, there's a survival benefit, not surprisingly, to earlier treatment. But I think we would just argue that it's just better for the patients, even if they're getting difficult news, to really have that quarterback piece. So I think, again, standardizing that. One kind of personal interest of mine has actually been patients who don't speak English, and how do they communicate, and they just don't have that same level of advocacy. So we'll be tracking that. We're gonna look at, we actually at Stanford have about 10% of our patients kind of across the board either report a different language that they speak or use an interpreter. So it's a decent chunk of our group. So again, it's really, there's an equity lens into all of this, and I know that, equity and health disparities, it's such a, almost just like a hot topic, like buzzword. And I really think about, there's been so much literature on it, but there's not been as much, I would say, implementation of like, okay, this is actually something you can measure. And then maybe we put more resources to saying, oh, you actually need a navigator. And everybody doesn't need a navigator, but it's like, who are those pockets of people who need help? So that's just one of the things that we're gonna try to do. And this is all very new to us. Again, I wanna stress that many of these seem very common sense, but just the medical system does move slower in, trying to get these off the ground.
And I love that you're trying to do that. So what does that look like? Are you involving the patients in part of this process?
Our hope is that it's actually going to lead to, honestly, patient self-referral. Again, we're really in baby steps, but other cancer centers have done this, where you can just call and say, hey, I had a abnormal scan, you don't need a primary care doctor to refer. I think the hardest thing for us, everything comes down to triage. You could not imagine, there's work queues on work queues and arrows and flow diagrams, and just how do you move a large body of people kind of through the medical system. So I do think that, honestly, a lot of this has been non-clinical traditionally. So, you talk to your lovely administrative person or scheduler, and we're really realizing, I think, that there needs to be a lot of clinical input. I've had someone who was initially diagnosed as anemia, just a low blood count, nothing major, pretty stable, ended up having a very aggressive type of cancer. But the kind of referral type, the referral name was anemia. That was it. And so if someone looked at that, they would just say, it's fine. So I think that's one piece, again, from a data point of view. You look at data, but you don't fully trust it.
Yeah.
And then trying to actually involve MDs. We're really trying to use nurse practitioners and physician assistants that I know many of you, I'm sure you have interacted with. They're so smart, And so, again, there needs to be an additional clinical eye on kind of saying, obviously everybody would love to be seen next day. That's not possible sometimes. So how can we be thoughtful on who gets seen, but just opening up new slots is honestly the first thing. And then I think you mentioned this, but I wanted to kind of highlight one thing that we haven't talked about is everything so far is reactive, if you notice. You message me, and then I say, oh, we should take a look at that. Or everything in general, I would say, is reactive, right? We're reacting to a symptom, we're reacting to a CT scan. There's a concept called patient-reported outcomes. And so the idea is, again, very simple, not rocket science, to say that people should be able to report their symptoms consistently between visits. Visits are this kind of arbitrary, almost made up checkpoint time, and you're living with this disease every day. It's been hard to implement, to be honest. There's been a lot of electronic tablet, how much diarrhea I'm having, how much nausea I'm having. And of course, if someone's feeling very sick, then they probably don't want to open up their tablet and, click some buttons. That seems silly. So we're still figuring that out. But I think the couple things we're really trying to look into proactively is, again, proactive symptom management is, I think, a big piece. We've done some, again, small pilots for that, but it's not something we've rolled out fully. So in the next 10 years, that's what I'm excited about, is saying I can proactively catch earlier symptoms. So that's one. And then the other thing we're really trying to do is also predict, just people who are sicker. Mm-hmm. Now, doctors usually know who are sicker, but are there people who need, let's say I see someone on a Monday, does someone need a check-in on a Friday? Does someone just need a phone call to say, hey, Monday seemed a little rough. Maybe you need a little bit more help. So those types of things, again, most patients are very good at reaching out to us, and we really rely on that. But the kind of, again, disparity lens to really say, for someone who isn't on my health, isn't reaching out to me, how do I make sure they are still taken care of? I think those are types of things that I'm excited about.
So from a side effect management, let's stick in that sort of lane for a second. What understanding patient-reported outcomes are an important part of that, but what role do palliative care specialists play in that as well, and connecting the dots there to ensure that communication is happening?
Yeah, I'm so glad you asked that. So our palliative care team, just like I think every palliative care team, and it feels like every medical specialty, everyone has a long wait, right? It's like your doctor puts in the referral and then say, let's say you're having really bad pain or nausea, they are lovely and they are very comprehensive, but sometimes they have to see you in 2 weeks, and 2 weeks feels too long. So one of the things we've been trying to do is with our discharge clinic, for example, to say, just recognizing that if you were in the hospital, unplanned, even if it was just for pneumonia, let's say, you are just inherently at a higher risk of a medical complication. So again, building some pathways to ask our palliative doctors, hey, for our patients who were discharged, could you save us some extra slots same week? They just might be at higher risk. And so those types of triage, that's what I think about on my non-clinic days, is like how, again, everybody would love to get everything all the time, but how do you build in triage? I think the symptom piece, I would say oncologists do, our group I think does probably 80% of it. We do a lot of it. And then we really use our palliative physicians when we feel like, gee, I really tried a lot of things and I didn't get that nausea controlled or the shortness of breath controlled and the pain controlled. But I don't think they have honestly the capacity right now, at least, to handle every single person all the time.
And capacity is definitely a big issue, and I think this is, again, one of those. So let me step back for a second. So just for those who might be watching that are new, or anybody in the room who hasn't heard me talk about palliative care, which would be shocking, as an important part of your overall care. A lot of times people confuse palliative care with hospice care, and although palliative care is part of hospice care in and of itself is end-of-life care, where palliative care is that supportive care that happens at any point in time along this experience. And so I, for one, in the 20 years I've been talking with patients and getting my own sort of patient-reported outcomes, right, have recognized this for a long time as being a very important piece for a couple of reasons. A, quality of life and pain management, like all of that type of thing. But also I know that quite often, and it's more often than not, when I have conversations with folks who don't have any sort of a palliative care team, like on their healthcare team, they're actually keeping from their healthcare provider the fact that they're having such trouble with their side effects because they're terrified that by divulging this information, their doctor is going to take them off a treatment that could potentially be killing their cancer. So it's so vicious, sort of the cycle. So having those conversations up front immediately at the time of, you're starting your treatment or deciding on your treatment plan, to have those conversations with your healthcare provider about supportive or palliative care is such an important piece. And I know I'm preaching to the choir with a lot of folks in the room.
Yeah, no, you're preaching to the choir here. I think from how I work with palliative care, they're really almost like a gut check for me. It's almost like a third party in the room because I think I get to know some people really well and, get personally involved. Like, I want to continue the treatment. I want you to do well. I want this to work. And it's almost like a little bit of a reality check from a physician who isn't so in the weeds, and especially with end of life, to be very honest with you, and especially if someone is definitely, younger, someone we've taken care of for a long time, no one prepares for that, even if you've done it many times. And I think my general approach, because I think about all these logistic things, I usually tell my patients, let me just put in the referral. Just meet them once, and then you won't need them. And then I'm always trying to play the game a little bit. So I'm like, okay, if you've seen them once, getting a return patient visit is much easier than a new patient visit. So I'm very good at little tips and tricks. I know that sounds very silly and childish almost, but I think that that's actually how I feel about second opinions a lot of times. I tell people, go get a second opinion so they have a medical record for you. And then now they have a medical record number, and so if you need them in 2 years, you say, hey, I'm an existing patient. I need a return patient visit and not a new patient visit. So if any of you ever need these tips and tricks, I've collated them. But it is, because there's an access issue in healthcare, I think it is important to be thoughtful of, if I got really sick, I probably can't get everything I would want tomorrow. And so I think that planning piece actually really helps. I think the last thing I wanted to note was, I think I already mentioned this, was advanced care planning. And so we have a form that we like to fill out where we just do a very basic, like, here is what we have talked to the person. From a quality team, we're sometimes unpopular because, again, we make people do extra things. But this is actually something we've tried to do throughout the center, is just saying, even if something's curable, has a great prognosis, let's say, there may be some value in just clicking that button, just so that anytime you interact with the medical system, they kind of know where your care is. And I think there is a bias with cancer in general, especially when people are seeing non-oncology providers. There's kind of this, oh, well, you have cancer. So, like, I remember I got a call once where I had someone who had resected, so early stage cancer, lung cancer, had surgery, and was on osimertinib, and had like a heart attack, essentially. And they called me and they were like, oh, like, should we like treat the heart attack? And I was like, yes, like, yes, like, put the stent in, like, yes, yeah. Like, you know, and that's an extreme example of a place I will not name, but, you know, just again, I do think there is value in some documentation, again, not a lot, to say, this is what my understanding is of this person I've really taken care of, and it's not a one-size-fits-all. And yes, please treat the heart attack, and please put the pacemaker in, and like, do all these things. So it's also about not just communicating to all of you, because again, for many of us, we feel like we have actually a really good relationship with our patients, and we know each other, and we have talked about it. It's also not to be in positions where other parts of the health system really don't know what's been discussed. So that's how I look at advanced care planning, not as like a, oh gosh, we have to have this doom and gloom conversation all the time, and we have to remind ourselves about how hard this disease is. Like, people living with this, you know it. But it's really, again, to, I think, inform other physicians, and so that's how we've been approaching it.
And I think it's really interesting because I have an advance directive. I've never been diagnosed with any, you know, anything life-threatening. I did it when my kids were born, because you just don't know, right? You don't know when the heart attack might come or the plane might go down. Yes. I mean, if we're being honest. And I think it's such an important thing, and it's a harder conversation to have once a diagnosis has happened, because having the conversation sort of lends itself to, oh, what you're really telling me. Same thing with palliative care, right? You're sending me to palliative care, you're sending me to die.
Yeah. You
want me to talk about my advance directive, now you're telling me I'm gonna die, right? And that's not the case. And so how do we change the narrative around this so that people don't feel threatened by such important pieces of this sort of pie?
Yeah. No, so that's actually been a big part of like our kind of quality program, is we really have a lot of people who pass away, unfortunately, on their own in the ICU, you know, and again, as I said, we review every death that's related to cancer, at least in our institution. And so you really just you actually see heartbreaking cases, but we also review just these kind of amazing cases of, you know, physicians coming together, patients and their families coming together. So I'm very interested in how do we document also good work. Quality improvement is really seen to be kind of almost, I would say, just pointing the finger. Oh, you didn't do this right, and you didn't do this right, and this right. But I would say we see some amazing things happen, and we see some amazing care happen. So that's one thing I'll let you all know once I figure it out. But like, also rewarding good care, rewarding good doctors, rewarding good nurses, and really, again, to this kind of burnout thing that you always hear about, right? People are leaving medicine and things. That's a whole other piece. But I'm also interested in that, is that, you know, there is a patient experience piece that we talked about. I think that there's no doubt, I think, is priority one. And then I think as long as we can take out some of this documentation and measure things, I'm hoping that the people giving the care also will be happier.
Agreed. I do have one more question, and it's really around some of the things we've already discussed. We know healthcare providers have limited time. It's by no fault of your own. If there were 5 times as many hours in the day, there still wouldn't be enough hours in the day, right? And you're human. And so we've talked about human error, and we've talked about like a lot of these things. But you mentioned AI earlier on. We talked a little bit about electronic medical records and what role they might play in helping us to be more process efficient. What about telehealth, and what can we utilize technology and resources like that for to alleviate them having to be part of the 30 minutes that you talked about when we started this?
Stanford is doing some amazing work with AI. I am not directly involved because, again, I always joke that I really chose medicine to not be on the computer, and clearly I was wrong about that. So anytime I have to be on the computer, I'm a little begrudging about it. I think there's one program right now where they're actually having like an AI scribe to essentially capture exactly what we talk about. So instead of like a person, like you've seen scribes in your rooms, they're interpreting and still putting it into medical jargon. And if, gosh, any of you have seen your notes, right? Like it's just copied forward, large pieces of documents, really hard to piece together what's there. We honestly copy it forward because we just don't want to lose anything, honestly. That's why we do it. But there was this revolutionary idea of, well, how about you scrap that entire note and just documented word for word what was talked in the visit. And then you had like another model basically interpreted, and then I can get stage out of that, I can get my smoking history out of that. And so there's all of this is obviously very experimental and pilot, but I think the two things I hope that happens is doctors stop clicking boxes and just talk to people, and then we figure out on the back end how to capture that. That would be like my dream come true, and I would retire. So that's one. And then I think number two is that a lot of, again, pragmatic care delivery. There's so many times I've seen a patient and then the scan is the day after, and I'm like, what? Like, what was the point of that? Like, why did that even get scheduled? And why can't patients schedule their own scans? And so I do think, again, leaving that 30 minutes for true medical decision making and conversations, end of life planning, mental health, I think that you can actually do in like a good 30 minutes if you didn't do all the other stuff. And I really think that's where technology can help. I think one thing that we are struggling with a lot is that, again, we're measured by a lot of things, and then a lot of those metrics are not real. So we're also really trying to pick apart, again, picking maybe 5 things that we really think truly are accurate also and are measurable, and then maybe doing away with some of those measurements. Because that's, I think, really where frustrations come, is that, oh, you're telling me that I only have this 50% of my patients are staged, but I've written it down, I've had the conversation, but there's the huge documentation frustration that I'm hoping that kind of technology can solve for us.
Yeah. I did see some sort of quizzical looks when we started talking about PRO, patient-reported outcomes, and what that actually means. And to put it very simply, all of us, whether in the healthcare world or other, or you went and shopped somewhere, have been asked to take surveys. And that's basically what patient-reported outcomes are. GoTo has a lung cancer registry, lungcancerregistry.org for anybody who's interested, another shameless plug. But really the purpose of it is for us to hear from you so that we can mine that data that you're giving us, find the gaps, and fix the problems, right? So that's really what it's about. So it's a pain in the butt when somebody's like, would you mind taking this survey? You don't have to take it at that minute, right? Maybe over your coffee in the morning or your cocktail in the evening. Most of them take anywhere between 10 and 20 minutes, do not have to be done all at once. But they are so important when we're talking about affecting change in one place or another, whether it's in the quality of care you're receiving at your healthcare center, or we have a survey out right now for caregivers. Like, we're trying to identify what the needs are of caregivers. We know they're there, we know they're great, and it's been looked at and it's been studied, but what can GoTo do to help fill those gaps for the things that are missing from caregivers and family members who are helping their loved ones through this process. So surveys are important, people. I know they're a pain in the butt, but they do really help to inform people like Dr. Roy, who are trying to implement these changes in Stanford in particular, but that can then be emulated in healthcare centers around the world, really. So
Yeah, I'll just say two quick things. The idea for me, for PROs, patient-reported outcomes, came from like people bringing in notebooks, right? Because we say, how have you been feeling in the last 2 weeks? And gee, I don't really know what I ate like 2 days ago. So, it's, again, not brilliant work here, I acknowledge. But it is just trying to recognize there's data, actually, to say there was a big paper done at Sloan Kettering in New York. If you can track someone's symptoms of how they felt over time, then the idea is early intervention. And so maybe someone always feels 8 out of 10 pain, and you can't do anything about it. They just say it's 8. Well, if that 8 changes to a 10, you pay attention. But if someone who always says 1 out of 10 pain, but they have an 8 out of 10 pain, that's an emergency. And again, this is a lot of Dr. Gestalt. I kind of know my patients, and I kind of know how they're usually feeling. And so there's some people, when they say, oh, gee, my hip hurts, I'm like, oh, you usually don't say that, like, let's pay attention to that, right? So it's, again, a lot of what we do as human beings, but just trying to, again, take that human piece a little bit out of it. So it's not like, oh, I'll remember to follow up because you had pain, but there's like a documented piece. The reason we're excited about patient-reported outcomes is that it's actually been shown to improve survival in metastatic cancer, and as you all may know, showing that in a clinical trial is very hard. So that's just things we wonder about is there a good way to do it? They're annoying, and so we're trying to figure out, is there a less way to not make it annoying?
it's really interesting, and I tell folks this all the time who are like, well, should I take this survey or become part of this registry? And I use 23andMe as an example, right? So I've been a 23andMe sort of person. I spit in the cup, I don't know how many years ago. And every once in a while, they'll send me emails, and I can answer all these questions and take these surveys. And sometimes, like, when I might get a lunch break or something like that, I'll be like, oh, I'm going to go in, and I'm just going to answer a bunch of these questions. And it's fascinating what it will give me back, like you are like XYZ of the population or whatever, or help tell me that I'm more likely to have brown eyes, like, go figure. But it's really fascinating because some of them dig even deeper into health history, family history, and that kind of stuff. And I know I do it because I know that all of it is to help better inform, maybe not even me, but the people that will come after me, right? And so I do love playing a role and sort of being a part of that. And I will stop talking. A huge thank you, everyone, to Dr. Roy for coming out and talking with us today.
Thank you. Thanks so much.
It's been an amazing conversation. We hope you'll come back
would love
and
to.
talk about, who knows?
More things,
more things
that we need to fix.
Absolutely. Penn Media for coming out and setting up all of this. Onyx and Ash for doing the beautiful job we know you will on editing this and getting it out to the masses. Michelle Zay, my partner in crime when it comes to the living room back there in the corner. All of GoTo staff. For everything they do day in and day out. And of course, our supporters, without whom we wouldn't be able to bring this programming and our other support and education services to you. Amgen, AstraZeneca, Bayer, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, and Takeda. Whew, thank you all for all of your support. And we'll see you next time. Thanks, everybody.
So I'll be brave if you're brave. I'll be brave, but only